So before we end today's discussion, let's talk about using checkpoint inhibitors in patients with malignant pleural mesothelioma. I'm going to ask Naiyer to summarize that data, but we talked about Bev being an advance in the first line. This is still a disease where after first line we don't have a lot of great options. Thoughts about this disease in immunotherapy?
Well, I think there's data to come. I think that tremelimumab was the CTLA-4 agent that showed cases of clear response in mesothelioma. There's a randomized trial which is in process with tremelimumab.
In orphan drug designation?
Yeah. And certainly the most recent data with pembrolizumab showed in the PD-L1 positive patients, which was about half of mesothelioma, there was about a 20% response rate. And meso is another interesting story because it's also carcinogen, asbestos exposure, but they're not very mutated tumors.
Yeah, it's interesting.
They have a relatively low mutation burden, so biologically they're quite different. So, but I think there's clearly activity.
Yeah, I think that was some of the more recently exciting data in mesothelioma, the Bev data we talked about, but this was encouraging.
Yeah, at the AACR, right, this year. It was very, very exciting. And I've talked to patients about it since then, and you just need to find trials.
Yeah, and I think we've alluded a lot about clinical trials, but I think it's important to reinforce that most everything that we do in our practice has some basis in a clinical trial. Either the data has driven our decision making, or it has provided data that has shaped the way we think of populations maybe outside of the clinical trial. We try at our center, I'm sure you all are alike, to say that the best treatment that a patient has is a treatment in a clinical trial, because it's really trying to advance stage. And I point out to my patients very often that my standard of care recommendation has come from a number of trials that have been done over the years by some of us and by our prior colleagues and these sorts of things. So the concept and the commitment to clinical trials is important to what we do in oncology. And there's certainly in immunotherapy not a lack of trials. A number of trials, Jeff made this point earlier, that there are a number of agents, and so patients should have access to these things. And I have found that since ASCO, almost every new patient I see comes with the word nivolumab written on a piece of paper. So I think it's important to reinforce this concept of clinical trials.
Right. So clinical trials are why we're making a difference and leading to change here.
One clinical challenge has been what we do with the patient that comes in with an autoimmune history, and every week this comes up, and I'd be interested to know what people's approaches are.
There's a clinical trial being developed for that exact question.
No, but two questions. I want to comment on the trials, but to Nair's point, you have to ask, if someone comes in with a history of an autoimmunity, how serious was it? They say they've had rheumatoid arthritis. How serious was it?
How well
were they on
documented
steroids? Are they on steroids now? Because I think at some point, as these drugs are approved in clinical practice, we'll have to use our judgment.
Right.
And we'll have to just look, because what are the other options?
I had a patient who was we found while screening for a PD-1 study to be Hep C positive. And of course, looking at the literature, you'll see that nivolumab is being developed as a therapy for hepatitis C with some effect.
But they're excluded from the trial.
They're excluded from the trial.
From the
So
trial.
we treated him off label. I'll say I treated him off label.
Well,
that's
probably okay because you have hepatocellular
My
carcinoma
point is
data.
we're pushing the boundary here, and we all need to do that and describe our experiences as we do it.
But I will say, for clinical trials, the master protocols that are out there are an important component of these as well. Many of us are involved with that, because most patients in this country are treated in the community, and we need to make sure that there are clinical trials that can be done in the community setting. The lung master protocol, for example, in squamous lung is looking at genetically driven drivers for squamous. But we also have two arms now that will be with immunotherapy. One is ipilimumab, nivolumab versus nivolumab. So we're taking that combination out to the community. And I think that's really important, because there'll be a clinical trial. If a patient doesn't have a genetic driver, they go on that. And we're also looking at tremelimumab plus the MEDI4736 durvalumab. Is that what you've taught me it is?
Yeah.
So we have trials now that we're seating in 500 plus sites around the country. So it's important that we have trials that are community ready, that allow patients to go on them. You know, 'cause
And I think that trial, is answering a question which, patients ask me every day is, if I progress on nivolumab, is there an will immunotherapy combination work? And, we don't know, so I think that'll be useful.
We'll get to the tip of the iceberg because there are so many other immune inhibitors, which probably don't have time to talk about, but it's an exciting field, and the science is going to drive things. So clinical trials and clinical trials with biopsies will really help us to figure out what's next.
Yeah, but often the number one reason a patient doesn't go on a clinical trial is because they say their doctor didn't recommend a clinical trial. So it comes back to us in doing that. This is